Our next paper is Reduction in Unplanned Intubations After Children's Surgery, a Quality Improvement Project. This will be presented by Peter Juveler.
Thank you. Postoperative unplanned intubation is associated with mortality in pediatric patients with neonate status identified as an independent risk factor. In 2017 and 2018, our children's hospital was identified as a negative outlier in NISQIC pediatric for unplanned intubation events, and we formed an improvement team in response. Data from this Pareto chart of unplanned intubation events in relation to age informed our planning phase. Greater than 85% of unplanned intubation events were seen in children less than 1 year old. This information targeted our efforts towards this age group, the majority of whom were treated in the neonatal ICU. We formed an interdisciplinary improvement team in summer of 2018, and a postoperative extubation checklist and post-op pain management guideline were implemented in September 2019, with data presented through June 2022. Here's a key driver diagram with this project highlighted in orange. Our global aim was to decrease unplanned intubation for all patients in the Children's Hospital, and our SMART aim was to reduce post-op unplanned intubation in the NICU by 25% in 1 year. Primary drivers of oversedation and extubation readiness yielded secondary drivers which led to change ideas. The pain guideline consisted of minimizing opioid infusion and prescribing all patients acetaminophen 48 to 72 hours post-op. The 10-item extubation checklist had no individual requirements for yes or no, and was completed and signed as part of the medical record. Baseline data consisted of 200 children with 145 children post-intervention. There was no difference in the following demographics and comorbidities which have been associated with unplanned intubation: age, operative time greater than 120 minutes, oxygen support, and ASA class. NICU unplanned intubation decreased, resulting in a 76% reduction in events. Post-op opioid prescribing also decreased. Patients receiving opioids decreased from 85 to 51%. Patients receiving opioid infusions decreased from 65 to 21%. And post-op acetaminophen prescribing increased from 25 to 90%. This is a control chart that displays the number of NICU post-op unplanned intubation events per patient by quarter. The average proportion of postoperative unplanned intubation events decreased from 0.27 to 0.07 events per patient, which equates to 11 fewer unplanned intubation events in our hospital per year. This control chart demonstrates morphine equivalents per patient administered in the NICU, 0 to 40 hours post-op by quarter. Morphine equivalents per patient decreased from 39.5 to 7.9 equivalents. Checklist compliance reached and maintained our goal of 80%. There was no difference in balancing measures, including hospital length of stay and pneumonia rate. Mortality decreased from 6.5 to 0.7%. 2 of 13 mortalities experienced an unplanned intubation event pre-intervention compared to 0 of 1 post-intervention. Ultimately, consensus plus a cognitive aid decreased neonatal ICU unplanned intubation rate with a checklist to guide post-op extubation discussions, plus a post-op pain management guideline to reinforce non-opioid pain management. To our knowledge, no attempt to reduce unplanned intubation events in children has been described. Unplanned intubation may be an important target since it's related to mortality, although in this study, mortality is likely related to other factors as well. Thank you.
Open for questions. Did you find that there were any particular operations that were more prone to reintubation in that previous cohort?
There were so few events. You mean not mortality? Yes. No, we're going to do further evaluation for apparent cause analysis to try to get deeper into the operations, but there wasn't any difference between the groups that we could see.
Thank you.
All right, thank you.
Thanks.